Before I begin my opening remarks, I do just want to personally comment on our loss in the Senate of former Senator Mike Enzi. He sat in this seat. I had the opportunity to work with him many times, especially on workforce issues. He chaired the Budget Committee. He was always believed in his philosophy, which is everyone's right, but he was accommodating, he was a listener, and I know I speak on behalf of all my Democratic colleagues, and I'm sure my Republican colleagues as well, that our thoughts and prayers are with his family today. Earlier this year, Patty Hayes, who is the Director of Public Health for Seattle and King County, reflected on the pandemic and noted, one of the big things that the entire country realized that is if you allow your public health infrastructure to be dismantled, then when you have an emergency of this sort, it is not ready to handle it. And she's right. I've been pushing for greater investments in public health for years because even before this pandemic, the diminished state of our public health infrastructure was incredibly alarming. Since 2010, spending for state public health departments has dropped by 16%, and spending for local health departments by 18%. In 2019, less than half of our states spent even $40 per person on public health, with only a few states spending over $100 per person, even though our healthcare spending was over $11,000 per person. Nationwide, local and state health departments have lost nearly a quarter of their workforce since 2008. In other words, before the pandemic struck, public health departments across the country were woefully understaffed and underfunded, and our nation was unprepared. How are we supposed to test for diseases like COVID-19 and sequence for new variants without modernized data systems and adequate lab capacity? How are health departments supposed to do contact tracing when a single case can have over 70 contacts, but a city like Detroit with 670,000 people has only 200 workers in its public health department? How are we supposed to track disparities when we don't have a consistent, standardized way of reporting the data we get? And when federal data doesn't often accurately identify some communities like Pacific Islanders? Beyond inequities, how are we supposed to track cases at all when data is coming into health departments by fax, thousands of printed pages at a time? Last July, in my home state of Washington, we brought in members of the National Guard just to help manually enter data from tests that weren't reported electronically. And then beyond the challenge of getting all that crucial data, how are we supposed to make good use of that data to fight public health threats when only 28% of local health departments have an epidemiologist or statistician? How are our communities supposed to get clear science-based guidance on public health issues, coordinate vaccination efforts to reach our most distant and vulnerable communities, or fight a deluge of misinformation about safe, effective vaccines when only half of all people in this country are served by a comprehensive public health system? We have to end the cycle of crisis and complacency in public health that led us here. As a public health leader in Kansas put it, we don't say to the fire department, oh, I'm sorry, there were no fires last year, so we're going to take 30% of your budget away. And we shouldn't be doing that to public health either. We need to dramatically rebuild our public health infrastructure, and we need to build it to last. We need to invest in modern technology in our health departments and hospitals. We need to invest in addressing inequities and making sure our data includes everyone, our vaccines reach everyone, and our health departments are building trust in communities of color, which we know are often hit the hardest when disaster strikes. And to do all of this, we also desperately need more people like Patty Hayes. However, Ms. Hayes retired from the health department this May. She's not alone. A survey taken before the pandemic showed nearly half of public health workers were considering retiring in the next 5 years. That's why it's so critical we take steps to build our public health workforce, including steps to help address the reality that outside of big cities, more than a fifth of local public health workers earn less than $35,000 a year. In her comments earlier this year, Ms. Hayes went on to say, and I quote, I'm hoping that the wisdom will prevail to really invest in the core public health infrastructure so that we're faster, better coordinated, and ready for the next thing. I'm hoping for that too, and I'm pushing as hard as I can to make it happen, which is why I introduced the Public Health Infrastructure Saves Lives Act so we can finally end the cycle of crisis and complacency in public health funding. It's why I've been pushing so hard for Congress to invest in public health in our COVID response bills, and it's why I've been pushing for our bipartisan work to reflect lessons learned from this pandemic. Of course, while the value of strong public health infrastructure may be the most important lesson we have to learn from this pandemic, there are many others we should be addressing as well, like the need to address supply chain disruptions, improve our stockpile of critical medical supplies, improve health equity, fight misinformation, prevent hospitals from being overwhelmed, and support and expand our healthcare and public health workforce. Additionally, Congress should enact an independent, comprehensive assessment of our nation's COVID-19 response to make sure we have a full accounting of this chapter in our history and never repeat it. I know that is a goal that we all share, and I look forward to hearing from all of our witnesses today. Thank you all so much for being here today. We look forward to your testimony. We look forward to learning what we can from this pandemic, and we will work with both colleagues on both sides of the aisle to act on those lessons. With that, I will turn it over to Ranking Member Burke.
Thank you.